Good evening, everyone. I'm Rashmi. I welcome you all to the first JC of the academic year. Our today's presenter is Sanyam Gupta, second year MBBS BMCRI, with the topic Pamrevlumab for Idiopathic Pulmonary Fibrosis, the ZEPHYRUS-1 randomized clinical trial. We have with us Dr. Sushma Madam, Associate Professor, Department of Pharmacology. Welcome, ma'am. With your permission, ma'am, can we start the meet?
Yeah, sure. Please start.
Over to you, Sayam.
Hello everyone. Good evening, ma'am. Am I audible?
Yes,
Yes,
Sanyam, you are
I.
audible.
Okay. Hello everyone. This is Sanyam Gupta, and I will be doing the first JC of the year. My topic is Pamrevlumab for idiopathic pulmonary fibrosis, a randomized clinical trial. Meanwhile, whenever I will be discussing parallelly, I will be checking through a consort checklist, which is specially designed for randomized clinical trials. It's a standard checklist which is used for the same purpose, and it's used for taking care that all the important aspects are covered in the article. So, starting with this slide itself, the type of study is clearly mentioned in the title, that is RCT trial, as well as the structured summary was given in the abstract, which I won't be sharing because I will be discussing in detail the rest of the article. Okay, introduction to journal and authors. The journal name is JAMA, Journal of American Medical Association, with an impact factor of 63.1. So, what's an impact factor? Is the number of citations which are published in an journal in the past recent years. So, more the impact factor, the better is the journal. So, being having a 63.1 impact factor is actually a very good thing. Okay, talking about the authors, the first author is Ganesh Raghu. He is an international authority in pulmonary disorders with a 35-year plus research experience. He has 370 plus research articles under his name. Second author is Lusa, who is an academic researcher in idiopathic pulmonary fibrosis as well and medicine with a total of 427 publications. And Evans, who is also a fellowship trained pulmonologist with research interest in pulmonary disease. The source of all this information was the web. I will be covering the presentation under the following headings: Introduction, Objective, Methodology, Statistics, Results, Discussion, Strengths, Limitations, and Conclusions. Okay, starting with the introduction, what is idiopathic pulmonary fibrosis? It's a rare interstitial lung disease with a progressive loss of lung function. So, patient experiences generally dyspnea, lethargy, inability to do daily works. It generally occurs in older than 80 years of age. As I will be discussing in this article, generally the mean age of participants was 70 years. CF is 0.33 to 4.1 people. Actually, this prevalence is a very, according to the article, it's published like 2-3 months back. So this prevalence rate is quite recent. Okay, talking about the pathophysiology, environmental factors such as smoking, dust particles, as well as genetic factors predispose an individual and can lead to alveolar epithelial injury. And we know that epithelial injury triggers activation of fibroblasts, which dysregulates the repair process and increases the matrix deposition and scarring. And once the pulmonary tissue starts scarring, it leads to pulmonary fibrosis. And this is progressive in nature. So the main goal in treating idiopathic pulmonary fibrosis is to decrease the decline in the rate of decline of the loss of lung function. Okay, because this disease is not treatable, so we are just trying to decrease the rate of loss of lung function. So here they have mentioned the scientific background why they are doing this research and proper explanation of with the rationale. Okay, talking about the test drug, which is Pamrevlumab, it's a fully human monoclonal antibody. It acts by binding to and inhibiting the activity of connective tissue growth factor. So it inhibits the tissue remodeling and fibrosis, and indirectly it is helping us decrease the fibrosis of the lung tissue. So it's helping us reduce the rate of decline of the function, not helping us to solve the disease problem. And recently, this is a phase 3 study. So in the recent phase 2 studies, it was found that this drug had a quite good tolerability, and the factors were quite favorable according to the phase 2 studies. So why this need of new drug came into being was The old drugs, the current drugs, which is the regimen which is accepted, is of antifibrotic drugs, which is pirfenidone and nintedanib. So this also reduces the rate of lung functions, but the tolerability to these drugs is quite less. And the patients, they did not experience improvement in symptoms or health related quality of life. So this demands a more effective treatment for IPF. So here comes the drug Pamrevlumab, which is, as I told, fully monoclonal antibody, which significantly slows down lung function decline, decreases the extent of lung fibrosis, and produces milder adverse event, which is actually a very favorable condition for the disease condition which we are dealing with. Also, talking about the treatment, if we don't give the treatment to the individual with IPF, the mean survival, the life expectancy of the individual is 3 to 5 years. So that's why treatment is quite needed. Okay, what was the objective of the trial? The objective was to confirm the efficacy and safety of pamrevlumab compared with the placebo for patients with IPF. So this article mentions the objectives clearly. Okay, talking about the study design, this study was a phase 3 double-blinded placebo-controlled randomized clinical trial study, which was conducted in 117 sites in 9 countries. This comprised a 6-week screening period, a 48-week treatment period, and a 8-week safety assessment period that lasted 8 weeks after the last dose of study drug. So they have mentioned the trial design and source of data properly, but they did mention who were blinded. But the patients, their attenders, the administrators, the regulators who were blinded, they have not mentioned properly. Talking about intervention and randomization. So randomization was 1:1. Each one of the groups received IV Pamrevlumab, and the other group received placebo. The drug was given every 3 weeks till the 48th week. There was subgrouping which was done on the basis of the antifibrotic therapy which the patients were taking already, and gender, age, pulmonary function stage. It's a grading criteria with which the patient was subdivided into subgroups. Study visits were planned for day 1 and then subsequent every 3 weeks till the 40th week, and pulmonary function tests were conducted first during the screening time when the first dose was given, and consequently every 6 to 12 weeks till the 40th week. So initially it was given every 6 weeks. The pulmonary function tests were done every 6 weeks, and the last 2 tests were done after the 12-week interval. Okay, so they have mentioned intervention properly, but they didn't mention how the sequence generation was generated. They didn't mention how they did the 1:1 randomization, and who was the person who implemented all this. What is the administrator, regulator, whom will we expect to be implementing all these things? And until the randomization was done, until the participants were divided into the 2 categories, 2 groups, where was the allocation, how was the allocation conceived? That also they have not mentioned. Talking about the inclusion and exclusion criteria, the patient was aged 40 to 85 in the inclusion criteria. Patient aged 40 to 85 years were taken. They were diagnosed with IPF within the past 7 years. The forced vital capacity was between 45 to 95%. The patients were naive to treatment, or they could have received an antifibrotic treatment that was discontinued. Okay, so this point becomes important as I will be discussing. Exclusion criteria: the participants might have received an antifibrotic treatment, but the last drug they should have taken 1 week earlier, and currently they should not be on any antifibrotic drugs. Okay, and they might be they might be a significant might have significant obstructive lung disease. So the force vital the ratio of expiratory volume in first second and the forced vital capacity for those patients, that was less than 70%, and the patients who have other diseases like emphysema, asthma and all. Okay, and for patients who had other comorbidities were also not taken in the study, and patients who showed sustained improvement in IPF within the past 12 months prior to screening. So eligibility criteria was properly mentioned in the study. This is important because, as I told just now, that they didn't take the patients who during the time of screening or who took the last antifibrotic drugs 1 week back, but they did an amendment in the protocol, and according to that, after 22 patients were enrolled, and according to that, the patients were allowed to take antifibrotic treatment during the therapy, but the condition was they should have worsening respiratory functional status, and this was decided by the study site investigators. Also, written consent was taken from all the patients prior to enrollment. So they have mentioned the changes after the commencement of the trial with proper reasoning. How did they assess the lung functions? So the primary criteria which they took was forced vital capacity. Other criteria which they took was the diffusing capacity of the lungs for carbon monoxide, walk test variables, patients reported outcomes which the patients reported through questionnaires, and health related quality of life. Okay. Now the primary outcome of the study was absolute change in forced vital capacity from baseline that was measured every 6 to 12 weeks with pulmonary function test until 48th week. The secondary outcomes were time to disease progression, time to any component of the clinical composite outcome, change in the quantitative lung fibrosis till 48th week, time to all cause mortality, and time to first respiratory hospitalization. In the secondary outcomes, the top three secondary outcomes were the most common. Exploratory outcomes were also mentioned, which the patients reported through questionnaires. So outcomes are also clear in the study. Talking about the safety analysis, the treatment emergent adverse events were summarized by the treatment groups. Clinically significant changes from baseline in the vitals were recorded till the 40th week. Hypersensitivity, anaphylactic, and immunogenic reactions were also monitored. There was a board, safety monitoring board, which was set up every 6 months to address all the adverse events which were found during the study, which included even the investigators of the study. Statistical analysis. The aim was to enroll 340 patients, which would provide a 90% power based on a two-sided alpha level of 0.05 significance for a two-sample t-test to detect a 120 ml difference in forced vital capacity from baseline. Now, why we are taking 120 ml is because generally, according to the natural course of the disease, it is seen that there is a decline of 150 ml of the lung volume in this course of time. So, according to that, they chose 120 ml difference from in FVC from baseline. The primary efficacy outcome was measured by a mixed model, which accounted to be a very good plus point of the study. Also, the mixed model for repeated measure approach was also used for secondary outcomes of pulmonary function test variables and other continuous variables. A Cox regression model was also used for other event variables. So, some of the patients after the study they died, or because of unseen circumstances, they were unable to take all the doses of either the test group or the control group. Because of that, some missing data was there. So those analysis was also done using the mixed model approach. Missing start and stop dates for prior and concomitant medications, procedures, non-drug therapies, and adverse events were imputed. The worst observed values after baseline were applied for all death analysis. The treatment effects were summarized with point estimates and a 95% confidence interval. So statistical analysis was also very clear in the study. Talking about the results, as I told, from 117 sites in 9 countries, the patients were recruited between July 18, 2019 to July 29, 2022. That accounts for 3 years. And the last follow-up encounter was in August 28, 2023. Now, if you notice, this, including everything, this is for 4 years. But in the starting, I told that the screening period was for 6 weeks. The intervention period was for 48 weeks and the follow-up period was for 8 weeks. If you sum up all of this, it won't together account for 4 years. So this is some discrepancy in the article which I found, which was not clearly mentioned. Okay, so a total of 612 adults were screened for IPF, out of which 256 were excluded and 356 were randomized based on the inclusion criteria. In that, 181 were randomized to the test group and 175 were randomized to the control group. Out of 181, 146 completed the study in the test group and 131 completed the study in the control group. And this is actually very significant data because the attrition rate was quite less, the dropout rate was quite less. Because of that, 80% people in the test group and 75% people in the control group were able to complete the study. This was also one of the plus point of the study. All the enrolled patients received at least one dose of the study drug, and all the other missing drugs, as I told, were done using the mixed model approach. More than half of the patients already had started an IPF treatment with antifibrotics previously. The treatment groups were well balanced between the demographics and clinical characteristics during the baseline time. The mean age of the patients was 70 years, in which majority, around 72%, were men. The time of addition of antifibrotic treatment was not analyzed. So they clearly mention the sample size, the participants flow, the period of recruitment of those 3 years, the baseline data, the results of each outcome, and harms or unintended effects, which I will be discussing afterwards. Okay, according to the table, as I told, 75% participants completed the study in the placebo group and 81% completed in the test group. But a slight protocol deviation was found. 15% patients deviated from the protocol in the control group, while 17% in the test group. Okay, now what is missed infusion is because of some circumstances, the participants were not able to take the drug, which also included the COVID-19, because at this time is of 2019 to 2022-23, and that time only the COVID started. So because of that, because of the restriction in traveling and all, the patients were unable to take some infusions, which came to be one of the limitations of the study. But they came through across one more method, which I will be discussing afterwards. So including those missing those doses because of COVID-19 limitations also, the placebo group had 37% missed infusions, and the test group had 31% missed infusions. Now this is important. Baseline forced vital capacity was 2416 ml in the control group, while in the test group it was 2367 ml. Now why this is important is the difference here is 50 ml, which won't significantly increase in the final result. This is at the baseline. This result of FVC is at the baseline, which is 50 ml, which won't increase significantly afterwards. But according to the phase 2 trials, the difference in the placebo group and the test group was significant. That's why this study was not able to cope up with the previous results. Then antifibrotic treatments, which are told after the protocol amendment 2.0, 15% in the placebo group and 19% in the test group had the antifibrotic treatments added during the study. Okay, so absolute FBC was decreased by 57 ml in the test group, while in the control group it decreased by 108 ml. The least square mean decline in FBC was similar in both the groups, and there was no significant between group difference in the subgroups. In the initial, it was discussed that the subgroups were divided based on the GAP scores. So based on that, there was no significant difference. Also, the secondary efficacy and exploratory outcomes were also found to be similar in both the groups. Talking about the safety, treatment emergent adverse events were almost similar in both the groups, as well as the treatment emergent serious adverse events were also similar in both the groups. But due to the study, only one case was found to be there in the Pamrevlumab group to have the adverse events. So the adverse events, although were similar in both the groups, range from mild to moderate in severity. Very less number of very severe cases are found. Also, most of the common adverse events were consistent with the progression of the disease. According to the clinical course, the amount of the lung function decline which should be there and all the symptoms which they should experience, like dyspnea, inability to do daily works, lethargy, tiredness. So all those things which they were unable to do, those type of symptoms which were inclined towards the clinical course were only found during the study. At baseline, only 2 patients in the test group and none of the patients in the control group had anti-drug antibodies, while at the last assessment, 1 patient in the control group but no patient in the test group had the antibodies. A total of 46 patients died in total, 23 in each group, in which 31 died within the 60 days after the last dose during the screening period, and 15 died beyond the 16 days of the last dose. And no deaths were deemed to be related to the study drugs. So whatever drug we are giving in the test group, none of the deaths were related to that. So mostly it might be because of the progression of the disease or the natural predisposition. Okay, now discussing. So the primary factor which was taken was forced vital capacity, and it was thought over that according to the phase 2 results, the phase 3 results will show the similar effects. That less lung function decline was expected. But this didn't mean the primary outcome. The primary outcome was related to FVC. So although in the test group, the Pamrevlumab group, that numerical value of the forced vital capacity was less than the placebo group, but the difference was not significant. I told in the baseline the difference was only 50 ml, but at the final result, the difference came out to be 70 ml. And actually, this was not significant. Also, the secondary outcomes were also not favorable in the test group. And the adverse event profile in the current study was consistent with the published reports. So there was no separate adverse events which were reported. The most important thing which comes out to be, after the finishing of the study, they planned for an open label extension as well as a companion trial, ZEPHYRUS-2. But because of the unexpected results of the study, they had to terminate that. So they had proper stopping guidelines and interim analysis were done properly for the study. So what can be the possible reasons for failing to replicate the prior results of the phase 2? One of the reasons can be smaller cohorts of patients. Other can be patients had more lung function impairment. See, the majority of patients are 70 years plus, and that also in that in their severe stages. Because of that, they had more severe symptoms at the baseline itself. So we can't expect them, in comparison to the phase 2 studies, to show better effects. Also, there was a longer interval from diagnosis to study enrollment. So the diagnosis can be from the 7 years back, and the study enrollment can be 7 years afterwards. Like the duration might be till 7 years also. So that there was a long interval between the diagnosis and study enrollment. Also, patients were allowed to begin treatment with antifibrotics during the study, which was a protocol amendment 2.0. Okay, since COVID-19 was unforeseen, because of that, they didn't make a separate subgroup for COVID-19 patients. So a separate analysis according to COVID-19 was not done. Also, no COVID-19 related trial protocol deviations were reported. Patients reported that because of COVID-19, they had some treatment emergent adverse events, and COVID-19 was one of the reasons for missed treatments, which makes sense also because there was a restriction in their traveling and going to the labs or the hospitals where the trial was conducted. Infusions was allowed at home itself with the specialized medical professionals, which improved adherence and willingness of the patients to continue the treatment during the pandemic. So, trial applicability and interpretation was consistent with the results. Okay, now IPF has a high mortality rate because the mean age survival age is still 3 to 5 years. So, this results in new treatment options need. Also, the rate of FVC decline alone may be insufficient to capture all the clinical meaningful changes in patients. So, other than forced vital capacity, we need other factors also to be taken into consideration in the future researches which are done on the same aspect, such as respiratory hospitalizations, mortality, patient-reported outcomes like questionnaires. They should also be taken into consideration. What were the strengths of the study were? It was, first of all, it was a randomized clinical trial. They had a diverse population, although the sample size was small, but they had a diverse population. Because in the previous study, like the phase 2 study, the sample size was around 10,000. So although sample size was small, but it was diverse. The attrition rate was low, that means the dropout rate was low. So patients adhered to the treatment till the very last, which was like 81% in the test group and 75% in the control group. Okay, for quantification of the CT scans, use of machine learning was used to quantify imaging of the fibrotic tissue as a pre-specified outcome, and a mixed model approach was used to fill all the missing data, and it was aligned to the US FDA recommendations to advocate patient-reported and quality of life outcomes with the objective to measure the disease progression in patients. What were the limitations of the study was? The main limitation was addition of the antifibrotic regimens after the starting of the study, which interfered with the normal course of the drug, which is the test drug, even the placebo group. So we can't appreciate the real effect which those drugs might have when the antifibrotic treatment regimen was not added. Also, there was a long duration, like same point which I told before, there was a long duration of enrollment between the diagnosis and the enrollment period. And taking only FVC as the sole, as the primary criteria would not be that great. They should prefer taking other criteria because FVC will stand as standalone outcome. So the final conclusions which comes out to be, among patients with IPF treated with Pamrevlumab or placebo, there was no statistically significant between group differences for the primary outcome of absolute change in FVC from baseline to week 48. So trial limitations are mentioned. Registration number, full trial protocol, and source of funding were mentioned in the article. Thank you.
Thank you for the presentation, Sayam. Sushma, ma'am, would you like to add, give any comments?
Um, First of all, Samyam, it was a very good presentation, and I just want all of you to know that my contribution to this whole presentation is absolute zero. He did everything on his own, so I really want to congratulate him on reading the article so well when you're so young. Okay, so and he only
Thank you.
asked me few queries which I really didn't answer also, I guess, because I was on leave and I was at home only on WhatsApp. He couldn't ask me anything, but I really want to appreciate your hard work for put it towards this journal club, which is very very good. And this is a very little tough article to start JC, but anyways, you have done a very good job. My only concern was not, I don't know whether I could not see, I'm seeing it on the phone actually, so I don't know whether I could see the tables and graphs and all that, or you didn't put it on the slides.
Ma'am, this thing, the flowchart I had put in the slide,
Okay,
but
okay.
the outcome graphs, the statistical graphs and all I didn't put.
Yeah,
Like they
yeah. So
told, like
the,
it was,
it's usually, yeah.
yes,
But
ma'am.
it's okay. It's okay for the first time. But ideally, what we do is it possible for you to put up those tables through, even
Yes,
through the
sure.
article is fine, even if it is
I'll
not there on the slide.
screen share that one.
Yeah. Through the article itself, you can share it
Yes,
through
ma'am.
the PDF. And see, what we want to do in a journal club is we want to study the table so that when you write an article, you should understand how a table is written, how a flow chart is written, and a little bit more on statistics. This is, uh, as I told you, to start with was a little tough article when we looked at the statistical analysis. The mixed model approach, even I am reading still. So, and Cox regression, we can speak a little bit more on that also, if possible. And then first of all, I want all of you to understand one thing, that whenever we do any study, if we get a negative result, we feel so disheartened and we don't want to publish and things like that. But this is a very good example of why a negative result trial also should be published. Okay, so because they published this, the continuation trial was stopped. Okay, the ZEPHYRUS-2 was on, they could have started it, but they stopped it because they didn't get anything really significant out of this trial. Okay, and then it also makes us question what was that phase 2 result was so encouraging, so that they started phase 3. So how they could have done phase 2 and how a drug molecule should go from phase 2 to phase 3. If you see this trial, there were like 117 centers involved, and it's hugely expensive to do randomized control trial. So how do we screen those drugs coming from phase 2 to phase 3 is also very very important. And I think next we will share one more article regarding this. Sanyam has it. That 3 times, I think it was a molecule from Fibrogen company, and they continuously lost 3 molecules coming out for IPF. So, what were all the mistakes of starting a phase 3 based on phase 2 result? That's what they have explained in that article, which was very, very nice actually. And starting from title to abstract to everything, I think Sanyam did very well. Can we just go to the tables as such? First table. Okay, so the first table gives always the baseline demographics, just to for us to understand that there is no much difference between both the groups. And I think here we could have seen, have they given with what was the lung functions and all that here, pulmonary functions? Was it different between both the groups?
No, ma'am. It
No,
was an
okay.
ideal
So it was
finding.
not, okay, it was not. So both are matched. So it is very important for you to put up this table and say that they are matched. Here, this is the only table, baseline demographics table, where we do not want a significant p-value. We do not want p less than 0.05 here. We want a higher p-value here, because we want to say that both the groups are matched. Okay, all of you got this? Baseline demographics table should be discussed and shown, saying that they both matched. So that's the preliminary important thing which we have to do when we start RCT. Okay, so can we just go to the next tables? Okay, so little down to the secondary outcomes. I'm seeing only exploratory outcomes here. Secondary outcomes. Okay, so here you can see, if you can move it, yeah. So they've given the number change in the outcome with means, and then about placebo, and then they've given what was the absolute difference with confidence interval and p-value. Here you all can see the p-value was not significant. Here I just wanted all of you not only to look at the p-value, you all should know how to look at the confidence interval. Okay, so what is the range, what is the importance of confidence interval? I want all of you to little bit read about what is a confidence interval, and how in every table it is not only the p-value and the other mean and SDs you are looking at, you are also looking at the confidence interval. Okay, so secondary outcomes, can you go down there? Can go to that exploratory outcomes, yeah, where there is hazard ratio given. There's no hazard ratio here.
Sayam, scroll up. It's in secondary outcomes table itself. The last
Okay,
second
right.
column.
We got it. Okay, so here I think the repeated measures mixed model as well as the Cox regression, both results are given. Yeah, actually, even it took quite some time for me also to understand what they want to say through these tables. So I just want all of you to look into what is time to event analysis, and through Cox we get some beta coefficient and hazard ratios and all that. Okay, how to interpret hazard ratio. And here, as I again told you, whenever you see hazard ratio, the first one you can all see 0.78. uh, confidence interval is between 0.52 to 1.15. So whenever the hazard ratio includes 1, that is, 1 is it's like the value of no difference. So when 1 is involved in the confidence interval, you don't see any significance in that treatment groups. Okay, so p is anyway not very significant here. So I wanted all of you to see that not only look at the p value and all that, look at the confidence intervals also. Okay, and then one more problem here what we faced is we were unable to download any of the supplementary material because it was not free. So even statistical analysis, there was a completely different supplementary article. We should have read that, and they repeatedly said that the mixed effect model for repeated measures was the strength of the trial. So that I think we all have to understand and read. And Cox regression, again, it tests some of the covariates. Do they have any influence on the result? All that, I think I just sent you a very small video on what is Cox regression analysis. We do JCs to understand the statistical analysis part a bit more. So I think it is not for the statistician. You have to tell your statistician what tests to be used, and you should be able to draw the result from the tables, whatever this SPSS gives out. You should be able to understand that. So I think from next time onwards, we'll spend 5 more minutes on biostatistics and understanding the tables, if that's okay with all of you. And then, in addition to whatever happened in the study, uh, what the author, I think Dr. Raghu is from Seattle, I think US, is pretty big name in IPF. So his comments are there all over, medical conferences and everywhere. So he repeatedly says that patient related outcomes are better, and then it's $1 million question whether FVC should be taken as a primary outcome, because FVC is a very complex variable which has a lot of physiological, pathological stuff mixed up, and then this IPF is very unpredictable progression. So to connect that with FVC was very difficult. So that was the main question everybody asked after this clinical trial. And I think there should be more importance to how the patient feels. Actually, even I had put my father on pirfenidone for 2 years, but repeatedly he said that he doesn't feel any really not good about taking it. It's not making any difference, except it gave him quite bad gastritis. So I sort of stopped it. And after that, the progression, you never know the progression. So that is one. Patient related outcomes are very, very important. And some of the other things what they mentioned in the next editorials is that, based on these, there is a lot of genetic factor also in IPF, and they have seen the progression and response to treatment based on this telomere length and all that stuff. So they want to subgroup these kind of people in phase 2 and select the right people for phase 3, so that that whatever they invest in, we should at least have a molecule out of it. So this biomarkers and molecular targets should be identified better in the other phases before we put the molecule through phase 3. That's one more discussion regarding this, whether FVC should be a sole criteria was the first question, and the second was why the biomarkers and molecular targets and all were not identified in phase 2, and only those people should have been put on to phase 3. And then the interaction between antifibrotic drugs and monoclonal antibody, when that was very questionable in the trial. Okay, so on the whole, from this JC, what we need to understand is, and then I think Sanyam also mentioned that blinding and allocation concealment and all that stuff is missing. I think Sanyam, we missed it because we couldn't download the supplementary article. I think all those information definitely will be there in that. We couldn't download it. So from next JC onwards, I think I just want all of you to go through little bit of the tables and the statistics, so that we all learn through it. Even smaller things like what's a p-value, what's a confidence interval, what is a hazard ratio, how to interpret a hazard ratio. So all that becomes very, very important when we start doing more JCs. So this is how we started first. So I think from next JC onwards, we'll just say 0.78 hazard ratio means what. Okay, in plain English, it means what. Some things like that we can discuss. I think some of my PGs are also there in the group. I don't know whether they want to share something. Was there anyone? Shreya, I think, is there?
Yes, ma'am.
Some,
So
yeah.
I think Sushma has covered most of the scientific part of it. What I want to say is, Sanyam, I think for a first presentation, it was a really impressive PowerPoint as such. I mean, it was very clean and pleasant to look at. Absolutely no spelling mistakes, and the alignment was proper. I don't know. It's really nice to look at. Usually, when people start with presentations, they do a lot of mistakes with these fonts and everything, and the colors, they go a little overboard. So I think it was a really professional looking presentation. So I want to commend you on that. I think everybody else can also take notes from Sanyam. And yeah, the scientific part of it, of course, whatever ma'am said, and probably next time, even you can approach us as well, and we'll also try to read up on it and help you all with it. So feel free to approach any of the PGs in pharmacology. So yeah, thank you for involving us as well.
Thank you so much, ma'am, Sushma ma'am and Shreya ma'am. We also have with us Dr. Shweta ma'am, Assistant Professor, Microbiology Department. Would you like to add any points, ma'am?
Hi, thank you for letting me in this WhatsApp group as well. So it was as commented by Dr. Sushma and Dr. Shreya. It was a very good presentation. Overall, it was very good, and I just wanted to reinforce what Dr. Sushma said, that we have to spend more time in the tables and to understand the terminologies and in, as she said, the plain English language, what those means, those parameters. And henceforth, we would also like to see more of infectious diseases as well as microorganisms and other components like product development. um, there are various other research parameters which can be put across in the journal club apart from RCTs as well. So the group can take it up. You can discuss with Dr. Sushma as well, and we'll be glad to help you out in those regards. Thank you.
Thank you so much, ma'am. Any questions from the audience?
If there are no questions, I think we can just end the meeting, right?
Okay, ma'am.
Okay,
Well,
and thank
presentation,
you.
Sayam.
Thanks to Shweta also for joining the group.
Thank you, Dr. Sushma.
Thank you so much, Sushma ma'am, Shweta ma'am, and PGs of the Pharmacology Department. I thank all the students for attending the meeting. Thank you, ma'am.
Okay, thank you everyone. Good night.